So, thanks so much, Elizabeth. So, can I introduce Dr. Elizabeth Best, who's a consultant psychiatrist with the Kent and Medway NHS Partnerships Trust Perinatal Mental Health Community Service. And Elizabeth is kindly here to present us with an overview of prescribing and medication used within mental health services within pregnancy and postpartum. Welcome, Elizabeth, and thanks.
Thank you so much, Trudy. It's so lovely to be invited. Thank you for including me in your webinar. And I'm so sorry for the previous speaker needing to stop. And so I do apologise to everyone for that being cut short. It's only that I need to leave at 3. So I'm really sorry I couldn't kind of stay longer. I will just see if I can share my screen. Da, da, da. Is that working for everyone?
Yep, so you can see your screen. So
Great.
just if you just launch the slideshow and then we can see you, we can hear you, and we can see your presentation. So that would be fantastic.
Touch wood, it's all good so far. Okay, so slideshow from beginning. Okay, hopefully that will work. Do shout out to me if you want me to do anything different, because I can only see the slides. Thank you.
Yeah, thanks, Elizabeth. It's not actually showing the slideshow. It's just it's showing us your first slide, but still with the bar at the top. Can you just try slideshow from the beginning again, or in the very top next to the refresh in the orange bar?
If I go back, so what I did was I pressed slideshow from beginning. So shall I do set up slideshow? Okay.
Yep.
Okay. Presented by speaker full screen. I'll try that. Is that better?
No, but don't worry, Elizabeth. It's much more important that we hear your presentation and your voice and all your knowledge. So you start, and I'll just stop you if you're not moving through the slides, so we can see your slides. That's absolutely fine. Thanks.
All right. I'll click on them when I'm changing slide to see if that works. So I'll let you know.
Yeah, that'd be great.
So thanks, Trudy. So I work in a secondary care perinatal mental health community service in Kent. And so the subject of this talk is about prescribing and medication used when considering pregnancy and postpartum in mental health services. So the first couple of slides, I've clicked the next slide. I don't know if that's worked. So I've clicked to the next slide, which should be about prescribing principles.
Yes, that's fine.
Thank you. So our team, we work, a lot of our work is about medication advice and decision making, and with patients, with service users directly, but also a lot of our work is advice kind of indirectly. So it's supporting non-medical prescribers, GPs, obstetricians, and general adult psychiatrists, kind of like common prescribers that we would be supporting. So yeah, the first couple of these slides are about the general principles we aim to adopt in thinking about medication for pregnancy and breastfeeding. And then a few subsequent slides have the main categories of the mental health medications we use, just to tell you a little bit more about them. So some of our principles that we try to embed within all our decision making is supporting service users to make their own informed choices, so have enough information to make the best decisions for them, and balancing the risks and the benefits of treatment with the risks and the impact, with the mental health being not well treated. So a lot of prescribers and the mums, like patients themselves, will have a lot of anxiety about the medication itself, but maybe not have enough time speaking with someone about actually what would the risk or the consequences be if your mental health is still not well treated. And there's studies showing the impact that can have on unborn babies and postnatally as well. So we try to do that in a way that not to cause any alarm or to make any service users feel guilty at all, but just to help them use that information in weighing up these decisions and using medications, hopefully with the lowest risk profile we can, the lowest effective dose for the person, and also as few medications as possible for each person. And also which medication has worked best previously for an individual is a really important kind of guideline for us on what's going to be most likely to help on this occasion. And balancing that out again with kind of safety information that we have. And a lot of our work, a lot of our take-home messages with prescribers is about trying not to stop psychotropic medication quickly just because a woman says they are pregnant or breastfeeding, and to get specialist advice, because with nearly all medications for mental health, the risks are not that high that kind of make that necessary. So the next slide, I've changed it my end, so I hope it's working your end. Is so for other principles include the need sometimes to increase the dose as pregnancy progresses and women's volume of distribution increases. That might be something to think about if women seem to be deteriorating a little bit in the second, third trimester. And also always bearing in mind if breastfeeding will be a possibility, thinking about options that are optimal for breastfeeding, if thinking about a medication in pregnancy, for example. So to try and think of something that's better for the mum longer term, rather than starting something and then having a conversation about switching medication to something that might be a bit better in breastfeeding, which I've seen some GPs doing, which is not ideal. And we'd always sort of think about extra precautions for babies that are more vulnerable, so premature babies, babies whose liver and kidney function are not optimal. So that's that kind of comes into our breastfeeding advice. We'd always think about the risk of sedation for the parent secondary to medication, and co-sleeping advice, and being very careful when we're talking about risks and side effects of medication in the postnatal period. Just shout out if you haven't got the slide that you think you should have, because I'll see if I can help with that if that's a problem. So yes, as I was saying, so most of the mental health medications we use have quite a reasonable safety profile in pregnancy and breastfeeding, only with a few exceptions. So the slide I'm changing to now is just, it says weighing up the evidence at the top, and it just talks about some of those exceptions. So I think everyone's probably heard about sodium valproate, again in the news, being a concern if men are taking it at the time of conception, but it's been well known for a long time about the high risks to unborn to babies if taken during pregnancy. So the few drugs that we would say to avoid absolutely in pregnancy would be sodium valproate and usually carbamazepine, and also in breastfeeding, lithium and clozapine are two that we would have to advise not to be taking. And a lot of our discussions with mums and parents are in response to patients kind of Googling and really over worrying or overthinking about something they've found, like where a study has found that taking an SSRI, for example, increases the risk of X. That so many studies have been looked at and analysed to try and find overall kind of conclusions. And a lot of the studies looked at individually will have confounding factors. And so it's trying to present all the studies and the findings from everything overall in a kind of that sort of context to potential worried patients. So the next slide I've got up on the screen, if it's working, it should say antidepressant use in anxiety and depression. So an area incredibly common for mental health in the general population and in perinatal women. So 10 to 15% at least of women in the perinatal period are suffering from anxiety or depression. And so this slide just kind of really gives you an overview of what's commonly prescribed. So first line in secondary care and primary care would be the SSRIs. And out of all of those, I would say sertraline probably gets recommended the most, mostly because it's quite a good combination in terms of pregnancy plus a shorter half-life for breastfeeding. And that's without other considerations, for example, like if someone has found something else very helpful in the past that wasn't sertraline, then we would give some more weight to that, of course. And paroxetine also has a good short half-life for breastfeeding, but we'd also educate patients about discontinuation, withdrawal symptoms being a bit more of a difficult issue with paroxetine, and to just bear that in mind. And then I've listed some other antidepressants that are used fairly commonly in secondary care, more so when they're second line. So if one or two SSRIs haven't worked in primary care, then the next category are kind of considered more commonly. And then TCAs are tricyclics, which are really old, the older antidepressants, and are used very rarely nowadays, really, mostly because of side effects, plus they're more toxic in overdose than the newer antidepressants. And when starting antidepressants, we talk to patients, of course, about potential side effects and also the wait, the delay and the kind of onset of improvement that's likely. So it's very likely that people would need to wait at least a couple of weeks before noticing improvement. Unfortunately, might get side effects before that. So a lot of people might refer to that phenomenon where they feel a bit worse for a while before they start feeling better. And that could be difficult. So it's a kind of just a question of how severe they are and what someone can tolerate with knowing that kind of information in advance. But overall, antidepressants have a very good safety profile in pregnancy and breastfeeding, and there are little kind of bits of information we would talk to people about that want, that would like more information. So very tiny increased risks in postpartum hemorrhage, tiny documented statistical risk for pulmonary persistent hypertension, for example. But something more common that we talk about with our patients as routine with most mental health medications is that risk of neonatal adaptation syndrome after babies are born. So a very kind of short-term self-limiting phenomenon about day 1 or 2 postpartum in about under a third of new babies, where they are adapting to not having the medication anymore, where they might seem jittery or have a tremor or be a bit sleepy. So we talk about this with pregnant women just to make them aware and reassure them that postnatal clinical staff are really familiar with this and can support parents and baby as much as they need. The next slide, I've just put on the category of short-term use of medication for insomnia or anxiety, so that sort of PRN use. So for benzodiazepines, we discourage them really as much as we can because of the risks of use at certain times of pregnancy and risks of longer term use. With breastfeeding, lorazepam short term is the lowest risk and can be advised as it has such a short half-life. And promethazine is something also really useful that we find in pregnancy for anxiety and insomnia, but we're more cautious with it towards the end, near the due date, and if breastfeeding. And propranolol is another short-term anxiety relief, which has a good safety profile in breastfeeding, but not advised really in pregnancy. And the next slide, the next couple of slides cover kind of antipsychotic and mood stabilizing medications. So they'd be prescribed in secondary care. So for a range of all psychotic illnesses, bipolar disorders, complex mood disorders, and at times also it's prescribed often for its anxiolytic properties. So I've listed the names there of ones that you would be most likely to see commonly used. Quetiapine, I would say, might be one of the ones you might see used a little bit more in low dose, used for the anxiolytic sense, particularly in patients who might not have one of those severe mental illness diagnoses, but they might struggle with emotional dysregulation, have a personality disorder difficulty that can also kind of get used in that area. So again, generally really good safety profile overall for prescribing when there's a need. So when there's really is a benefit to be gained by having this sort of medication prescribed to help someone stay well. And some of the considerations we think about and talk to mums about are some of the risks that go along with the medication. So they include gestational diabetes, so that's more a risk for olanzapine and quetiapine. Again, for those, they're the kind of the two that also are more the culprits for side effects of weight gain, sedation, thromboembolism risk. And also, again, the antipsychotics are possibly, they may trigger neonatal adaptation syndrome. So we've talked to pregnant women about that too. And something we talk about as well is if they would like to breastfeed, it's possible that breastfeeding might prevent or alleviate the symptoms of neonatal adaptation syndrome in babies. I've only got a couple more slides. So doing quite well for time, hopefully. So other mood stabilizers used in secondary care. So lithium is something that can be used. It's been useful actually over the years that the more the use of lithium is studied in pregnancy, the risk of cardiac defects for the unborn is actually being shown to be reduced to what it used to be thought of compared to the general population. So we would support women with bipolar or some sort of illness that's been recurrent or relapsing who have stayed really well on lithium. If they want to make an informed choice to take lithium during pregnancy, we would absolutely support them with that. And I'm sure you've come across patients in your work where if they're taking lithium, that they have a very strict protocol in pregnancy and labour and postnatally for monitoring. The main reason for this being to prevent lithium toxicity for the mum. And again, as I was saying, lithium is not advised in breastfeeding as the levels can be very high in milk. Baby's kidney and liver function is really kind of immature, at least for the first 3 months, and they're very susceptible to lithium toxicity if breastfed. In my last slide on the other mood stabilizers, so we talked about avoiding sodium valproate and carbamazepine due to the high risk of neural tube defects and developmental delay and impairment of cognitive function. And all mental health trusts will have a risk kind of protocol for sodium valproate in anyone of childbearing potential that we have to adhere to due to those risks. Lamotrigine is a mood stabilizer that we use quite often. Actually, it's got a really good, although it's an anti-epilepsy drug, it's also very useful in bipolar disorder, especially in bipolar type 2, which is a kind of the milder end of the spectrum of bipolar. So bipolar type 1 is a more severe end. It's women with bipolar type 1 who are much more high risk of postpartum psychosis. Just to give it a bit of context, so yeah, bipolar type 2, the periods of elation and manic phases are less severe, and it's more often characterised by depressive episodes that are difficult to treat. So lamotrigine can be really useful in bipolar type 2, has a good safety profile in pregnancy, and it is used in breastfeeding. I have to have conversations with women when thinking about it, just because the levels in breast milk are quite variable. And so we're quite cautious with lamotrigine, generally in the general population, about rash. So everyone who's started on lamotrigine we should have a conversation about if they have a rash to get medical attention the same day in case there's a risk it progresses to a serious complication called Stevens-Johnson syndrome. So if women are taking lamotrigine and want to breastfeed, we have the same sorts of conversation, just bearing in mind that potential risk for baby, although it's not really cases haven't been documented. So this slide, if this is all working, each time I change the slide, it should say useful perinatal prescribing resources. Now, I really apologise because I was checking this slide this morning. I was talking to a patient and checking it, and actually a couple of the links don't work. So before my colleagues who've organised the webinar send you the slides, I will edit this and I'll change the links to links that work now, so that I don't send you a duff slide. Thank you so much for fitting me in and for listening. And I know there might not be very much time for discussion or questions, but I can stay until 3 if anyone has.
Thanks so much, Elizabeth. We've just got a few questions from the panel, so we'll take it up to 3 o'clock if that's okay with you. And just to mention, I think your zip was touching the microphone during the presentation, so that's fine. It's not a problem at all. You were still very clear, but just to let everybody know. So just a few questions to the panel then. In regards to the pregnancy physiological changes on serum levels of the medication, do you test levels or do you up titrate in certain trimesters, or do you stay with the doses like lamotrigine, for instance?
So it's really unusual for us to check for levels, only for lithium, really, and for the others to just really go on a clinical picture.
Yeah. Okay, yeah, great. And then the other question was, what about the length of time for neonatal observations for SSRIs? Currently 48 hours of observation at St George's, but controversial. No,
Well, it's really
withdrawal
interesting that it's Yes, it's really interesting how different it is in different trusts. And so I'm really lucky to be on like a national group with the perinatal consultants across England. And so that's a conversation that comes up quite often because, so for Kent, if it's really only 12 hours, I mean, if a mum wants to stay longer, they can stay longer. But clinically, if baby and mum are fine, we don't, we don't advocate or say they should stay longer than 12 hours if they've had a straightforward delivery and they want to go. And especially if they're experienced and they've established breastfeeding, or, if there's no worries and they want to leave, that's fine. And so the conversations we have if we have like a perinatal care planning meeting in pregnancy, where mental health and maternity kind of join up and discuss someone's care if it's a bit more complex. So that's always part of the conversation. Like new mums especially will have, like, how long will I need to stay in hospital? What monitoring is needed for the baby? And our stock answer would be, you're welcome to stay for 24 to 48 hours. That should be enough. But it is interesting how different trusts, like you say, different parts of the country, is a different sort of theme. I think there are guidance, hopefully, like more national guidance being written, because there was some national guidance a few years ago. So I'm really sorry that doesn't really answer the question.
Patient flow, doesn't it? But it does.
Absolutely.
In a way. It tells us there's not a standardized approach. So that's something we need to be really looking at. Yeah. There is another one in the chat. And how are we doing for time? Got 1 minute. Is there an alternative to lithium, and are women counselled? Just wondering why they will want to use lithium despite risk of cardiac defect. So I think.
Well, to reassure people, the lithium risk of cardiac defect is much lower than we thought. So the alternatives to lithium would be the mood stabilizing antipsychotics or lamotrigine, and it's about working out what's worked for someone and what hasn't. So usually what I've would find is that the women who have started lithium and are committed to taking it, because it is a commitment to take lithium. The women who have started it, found it work brilliantly, and therefore continue it, are women where they've been very unwell on other alternatives. So that's just a sort of a consideration about if people are doubtful about continuing on lithium, what's the history?
Yeah, your screen's just frozen, Elizabeth.
Been prior
Oh, there we go.
to that, of what else has worked or hasn't worked.
Fantastic. Thanks so much, Elizabeth. It was a brilliant talk, and we're right on time. It's 3 o'clock.
So I might have frozen. I can hear you.
Yeah.
Sorry. Thank you so much for having me.
Yeah. Thanks so much. Okay. Bye.
All right. Bye. Bye.